Okay, everybody, good afternoon. Welcome to this joint ERKNet, ESPN and ERA webinar on the impact of RNAi medication on the management of patients with primary hyperoxaluria type 1 that will be delivered today by Jaap Groothoff. But before I introduce Jaap, some introductory and practical issues. For those of you that tried to join the webinar in January, that did not work and there was a technical error, but at least this webinar has been postponed until May 14th, if I'm correct. So we will have a new opportunity to have this webinar. My name is Tom Nijnaars. I'm an adult nephrologist from the Amsterdam University Medical Center in Nijmegen, and I will be your moderator today. And to ensure some good discussions at the end of Jaap's talk, I would like to ask you all to pose your questions in the question box to the right of your screen. And be sure to ask comprehensive questions, because if you put in the box, why is that? We have no way of knowing what you are actually referring to at the end of the presentation. And I'm delighted to introduce our presenter, Jaap Groothoff, who is an expert on primary hyperoxaluria, who already for years truly plays a key role in making the new treatment options for this rare kidney disease available to patients. And Jaap is a pediatric nephrologist, a full professor in pediatric nephrology, and until recently the head of the Department of Pediatric Nephrology at the Emma Children's Hospital of the Amsterdam University Medical Center. And his field of interest and research topics are related to pediatric chronic kidney disease and in particular primary hyperoxaluria. He is a member of the scientific board of the Dutch Kidney Foundation, a member and a former chairman of the steering committee of the Oxal Europe Consortium, focused on primary hyperoxaluria, was involved as a PI in 14 international clinical trials to date, is chair of the Dutch National Orphan Drug Access Protocol Committee on lumasiran. I'm very happy that I pronounced that correctly, because that's a really tongue breaker. But as such, he is of course the perfect person to present this webinar on RNAi therapeutics in the management of primary hyperoxaluria type 1. Jaap, the floor is yours.
Thank you, Tom, for your very kind words, and welcome everybody to this webinar. These are my disclosures, and these would be my take-home messages. I will start with that. So I think that the RNA medication primary hyperoxaluria type 1 patients, now I see myself, I have to remove myself, significantly reduce oxalate production. They have shown to be beneficial clinical effects with respect to decrease of stone attacks and preservation of kidney function, and they may in selected cases be an alternative for liver transplantation in those who have a kidney failure. And we think that they are not indicated in case of complete response to pyridoxine therapy. So let us sketch the problem why we would need these new therapies at all. The primary hyperoxalurias are very rare inherited diseases of the glyoxylate metabolism, and they all lead to massive endogenous oxalate production. Well, the word oxalate is related with oxalis or wood sorrel, and that's a plant that nearly exists completely of oxalate. And oxalate is a useless product of the body, and it can only leave the body via the renal excretion, where it easily precipitates with calcium forming crystals, kidney stone formation, and nephrocalcinosis. Now here you see a cartoon of what is supposed to be the normal metabolism of amino acids that are involved in the oxalate production. Hydroxyproline and glycolate are probably the most important precursors of glyoxylate, the first being a product from the collagen breakdown and the latter originating from vegetable intake. The peroxisomal enzyme alanine glyoxylate aminotransferase, or AGT, is the most pivotal enzyme for the rapid breakdown of glyoxylate to glycine. And so in normal circumstances, only a very small proportion of glyoxylate will be metabolized into oxalate by LDH, and that will lead to less than 0.0 millimoles of oxalate excretion per day. Well, in PH1, that is by far the most common type of primary hyperoxaluria. That is caused by a peroxisomal AGT deficiency, leading to the accumulation of glyoxylate, but also to a high oxalate production, but also to a high production of glycolate. And these two are the hallmarks of PH1. One of my co-workers have actually found out, Sander Gerelfs, with a stable isotope study in pH, that glycolate is by far the most important source of oxalate in PH1 patients. And that is important to understand one of the new drugs, as I will show you in a few minutes. Now, it's also important to know that there are some missense mutations that lead to the production of a partly unfolded AGT. So there is AGT production, but it's a wrong AGT. And as a result of this misfolding, this AGT has a wrong postcode. It doesn't go to the peroxisome, but goes to the mitochondrion, where it's not functional. Unfortunately, there is a coenzyme, vitamin B6 or pyridoxine, that can partly restore this misfolding of the protein, and therefore lead to sometimes even a normalization of oxalate production. And there are about 30% in the Western world and European world of PH1 patients who do have these mutations, but the situation in, for instance, Arab countries is completely different. There are hardly any B6 sensitive patients. Here you can see a slide on the what we have in the oxaluria database. We have nearly 950 PH1 patients right now, and over 1,200 all over PH patients in the database. And we know from this database that kidney stones and nephrocalcinosis are the most common presenting symptom, but we also found that 46% of patients have already complete kidney failure at time of diagnosis. And when you look at patients who are diagnosed at adult age, it's more than 73% who are diagnosed with kidney failure. And in the end, we saw in our data is that more than 70% will end up with kidney failure. And then it becomes a very nasty disease, and we do not know exactly at what eGFR level systemic oxalosis occurs. But we think that that in patients with the eGFR lower than 40, they are at risk for systemic oxalosis with storage, especially in bone, skin, in vessels, eye, and in the myocardium. So what can we offer these patients? A lot of water. Our recommendation is more than 3 liters per square meter per day. Citrate, which keeps calcium oxalate diluted, and for some patients, vitamin B6. But is it effective? And the answer, it is not always effective. What can we offer if patients have a severe kidney failure? The recommendation now is a combined liver kidney transplantation, either sequential or directly combined. And we found, based on our data in the Oxford Europe database, we think that there is good evidence to consider a isolated kidney transplantation in patients with a mutation who are really clearly B6 sensitive. But the overall conclusion is that over 70% end up with kidney failure despite conservative therapy, which is a life-threatening disease, and that nearly half already present with kidney failure, and only a small proportion response to B6. So there is really a need, was a need for new therapies. And now we have those new RNA interference therapies that aim to knock out a specific enzyme that is pivotal for the endogenous oxalate production of out of glycolate. And they are currently tested in phase 2 and 3 trials. It's lumasiran, that's its aim to block the enzyme glycolate oxidase. It's already approved by the FDA and the EMA for PH1 patients of all ages. And the second one is nedosiran, which leads to a blockade of LDH, which is a pivotal step for the final metabolization of glyoxylate into LDH. So technically, this would be a drug for all types of pH. So the RNA interference is a natural biological pathway that inhibits gene expression by targeted degradation of translational inhibition of the cytoplasmic messenger RNA by RNA-induced silencing complex. And this system exists naturally nearly in all eukaryotic cells. And to use this RNA interference as a therapeutic has a big advantage of an extremely targeted therapy with potentially no off-targeted effects. In pH, the idea is to interfere with the metabolic production of oxalate by either reducing the substrate formation or to block a precursor of oxalate in the final step. And this occurs by a double-stranded RNA that is targeted against the messenger RNA that encodes for the enzyme that you want to eliminate. And this double-stranded DNA is brought by a vector into the cell, cleaved by dicer into small fragments which are bound to activating elements, hereby forming a so-called RNA-induced silencing complex. And that leads to the cleavage of the messenger RNA of the enzyme you want to knock out, and hence inhibition of the production of the targeted protein. And one of the major challenges of this therapy is how to get this RNA in the cell implicated in the disease. And the factor that both companies use is N-acetylgalactosamine, and that's a sugar ligand that conjugates RNA and is highly specific for the liver, which means that no other organs are affected. And it makes the medicine also applicable by subcutaneous injection. So the first one, lumasiran, is a substrate reducing therapy, and that aims to block glycolate oxidase. And glycolate oxidase is pivotal for the conversion of glycolate into glyoxylate. That will lead to a reduction of glyoxylate and therefore also a reduction of oxalate, but you can appreciate that glycolate will further go up, and this is a downside of this therapy, that it will lead to very high glycolate levels. The idea that glycolate deficiency has no phenotype comes from an observation of a family from the Middle East with a GO loss of function mutation, and this family has no phenotype at all. And also in mice, GO blockade is well tolerated and leads to a decrease of oxalate secretion. And it does indeed works very well also in humans, as is shown by this pivotal study, the ERKNet study, that is a randomized controlled trial in PH1 patients with an eGFR over 30 and a high oxalate production, age above 6, with a 2-to-1 randomization, lumasiran and placebo. Patients were injected with lumasiran every month during the first month and thereafter every 3 months. And the main primary outcome was the urinary oxalate reduction in 24 hours urine at month 6, and you can see here that there was a 65% reduction, maximum even of 76% reduction of urinary oxalate excretion. And also important that more than 80% had finally levels of less than 1.5 of the upper limit of oxalate excretion, and more than 50% had a complete normalization of oxalate excretion, and there were no serious side effects. And here you can see on the left side this percentage change from baseline to month 6 in lumasiran in blue and placebo in red. And on the right side, you can see the absolute oxalate excretion over time in lumasiran and placebo. Plasma oxalate also decreased with 40%, but these plasma oxalate levels were actually all also at baseline in the normal range. The 12-month extension showed a consistent lowering of the oxalate excretion. Also, plasma oxalate remains normal, and most important, eGFR remains stable over time. Plasma glycolate indeed increased, but the labels were stable over time, and most importantly, there was no acidosis seen in none of the one of the patients. The 12-month outcome also showed some clinical responses. So you can here see on the left side the nephrocalcinosis scores at month 6 and month 12, and you can see that in month 12 there is about 46% improvement of the score of nephrocalcinosis. And here you see on the left side that there was also there was a comparison between the last year before start lumasiran of the number of stone attacks compared with the year under lumasiran therapy. You can see that there was a significant reduction. ELIMINATE B was an open label single arm in very small children, also in babies, and you can see that the effect was even more impressive than in the older children and adults, with 89% reduction of urinary oxalate in the very small infants. And you can see here on the red line, the smaller the patient, the better the response. And also here you can see that there was some clinical improvement over time with an improvement of the nephrocalcinosis scores. Most babies and small children had no stone disease, but nephrocalcinosis. And the last important study is the study in patients with kidney failure, the so-called ELIMINATE C study. That was an open label multinational study for all ages with the eGFR below 45, and the main outcome was a change in plasma oxalate at month 6. That was divided in cohort A, those were the pre-dialysis patients, and cohort B were the patients who were already on dialysis at the time of onset. And you can see here that especially in cohort B, there was in the dialysis patient, there was a very significant decrease in plasma oxalate at month 6. This slide also shows that there was a more stable oxalate level pre and post dialysis over time, especially at month 6. So the difference between pre and post dialysis plasma oxalate decreased over time. So now we have some data of the long-term effects up to 36 months, and you can see here from this slide that the effect is stable at 36 months. There's still a more than 60% reduction from baseline of the oxalate excretion. only in the eliminated C. In the dialysis patients over time, there seems to be a little less clear effect on plasma oxalate than in the first 6 months. We wondered, because we saw quite a difference between patients, if this was due to a really difference in GO blockade, and we did a small study in actually not 8, but in 4 patients with labeled, with stable isotope labeled glycolate, oxalate, and glycine, which we could measure before and after at least 6 months of lumasiran therapy. And the idea was that if you can measure the extent of conversion from glycolate into oxalate, then you know what the extent of GO blockade is. And here you can see the results of 4 patients. And this shows the contribution of glycolate to oxalate before therapy and under therapy. And you can see that there's a huge difference between the purple patients, number 4, and the red patients, number 2. And this is reflected by the rate of appearance of oxalate at baseline and under lumasiran, but also reflected by the urine excretion, where you can see that in the purple patient, the urine excretion at baseline was sky high, and actually nearly the lowest under lumasiran, and in the red patient, it was much lower at baseline, but by far the highest in under lumasiran therapy. So the conclusion was from this very small study that there is probably a significant individual difference in response to GO blockade by lumasiran. Well, the second drug is targeted against LDH, which is the final step of glycosylate to oxalate. And the first open label study, phase 1 study, already showed a sharp reduction also in oxalate excretion in PH1 patients, and it's nearly 70% of the PH1 patients had less than 1.3 upper limit of the oxalate excretion, and there were no serious side effects. And then the most pivotal study is the RCT in PH1 and PH2 patients. That's the difference with the lumasiran study. For the rest, it's nearly the same age, above 6, eGFR above 30. And the main outcome was the AUC of the % of reduction of 24 hours in 24 hours urine at month 6. And what is important, actually, I think that the outcomes are comparable with lumasiran when it comes to PH1 patients. So it's nearly 65% had a less than 1.3 upper limit of normal oxalate excretion at month 6, and 50% had a normalization of urine oxalate, which is exactly the same as in lumasiran, but important, no response at all in PH2 patients. The study in PH3 patients are still going on. There were the same side effects, only injection side effects, which was actually also the same as in lumasiran. And this shows you what the development program of nedosiran is. And they have a FDA registration for patients over 9 years and a normal renal function, but not yet for the EMA. They expect to get that in the first half of 24. So this is also an extremely important question. Can RNAi therapy replace liver transplantation in PH1 patients? Well, if you look in the literature, there are now 10 patients reported that have had a kidney transplantation under RNAi therapy with kidney failure. There's one case study of 5 patients on the lumasiran who showed good results. One case report was negative. I will comment on that. One on nedosiran, one on lumasiran given after transplantation, one lumasiran with stiripentol, which is a anti-epileptic that blocks LDH, and one combined, and that's a study with nedosiran lumasiran. So let's first look at the case series of the 5 patients on lumasiran after what happens after kidney transplantation. There was one patient who had one stone attack at month 1 and month 3 after transplantation, but those were from stones that were already there at time of transplantation, and at month 6 there were no events anymore. And the ultrasounds of the grafts were all normal at follow-up, and the longest follow-up was reported was 12 months. Here you can see the plasma oxalate course under lumasiran, and those who had a follow-up of 6 months and some had a follow-up of 12 months, they were normal, corrected for eGFR. So what you expect that eGFR in non-PH patients. But so this was the conclusion: no signs of oxalate nephropathy, normal range plasma oxalate levels at follow-up, no nephrocalcinosis or stones, but also no normalization of urinary oxalate, which is probably due to the fact that they all have large storage of oxalate due to the dialysis, the time on dialysis. Well, then is the case with the title "Early Post-Transplant Recurrent Oxalate Nephropathy in a Patient with Primary Hyperoxaluria Type 1 Despite Pre-Trans Lumasiran Therapy." That was a 39-year-old patient and who had a delayed graft function after transplantation, and then a rise of creatinine from 140 to 230. There was a biopsy performed, and it was a clearly sign of a type 1 rejection, but also some oxalate depositions. The patient was treated with anti-rejection therapy, and actually the creatinine nearly came to the same level as before the deterioration. So our comments were that actually there were only a few, if you looked very carefully at the case, only a few oxalate depositions in the patient with a long-lasting dialysis vintage, and so consequently systemically stored oxalate. There was actually complete normalization of the plasma oxalate on the lumasiran, and eGFR nearly restored after rejection. So I think that the title does not completely cover what is actually was going on in this patient. Then there's a kidney transplantation under nedosiran, a patient of 70 years old who was on dialysis for quite a long time, and the outcome at month 6 was a creatinine of 105, no signs of oxalate nephropathy, and actually a normal plasma oxalate. So this was actually a very good outcome. Then there was a plasma case of lumasiran which started after transplantation, and that also showed quite a good outcome. Then there was a case with combined stiripentol, and that's an anti-epileptic drug which blocks LDH and lumasiran. And the outcome was at month 12, and it was in a patient of 49 years old without B6 therapy, and the outcome was that the serum creatinine was 106, so eGFR of nearly 70, a slightly raised plasma oxalate of 20, and marginally high oxalate excretion at month 12. So the only strange thing here is that the plasma oxalate is actually a little bit too high for this eGFR. And then we had a patient, a seven-year-old girl who presented with end-stage kidney disease at age 5 with PH with a B6 negative mutations, and she was put on 5 times per week hemodialysis and peritoneal dialysis. She has had a sky-high plasma oxalate of 241, and it only dropped to 218 under this terrible regime dialysis regimen. She had clear signs of systemic oxalosis, and we started with lumasiran after 2 months. And you can see that the plasma oxalate dropped to about 114 and stayed there at that level. And then we added nedosiran, and we transplanted her when she had a plasma oxalate drop to 55 after 5 months of combined therapy. Unfortunately, we had to stop them 4 months after the kidney transplantation due to problems with the insurance company. And now she is only on lumasiran therapy, and her creatinine is now we are now at month 18, and the creatinine is still about 77. And but she has quite a high urinary oxalate excretion still, and her plasma oxalate is slightly increased. So in conclusion, lumasiran is a very safe and also effective therapy in lowering urine oxalate excretion. There are some good data that it probably preserves kidney function. It's effective in lowering plasma oxalate in PH1 patient with kidney failure. The clinical effectiveness, we need more long-term data to be sure of that, but there are clearly signs of clinical efficacy. There's a potential for that it can function as a replacement for liver transplantation in selected patients. It's FDA and EMA approved, but there might be a significant difference in genome blockade between patients, and we really need to find out what is the cause of that, and if some patients should have a higher dosage or should be more eligible for nedosiran, because that's also a safe and effective medicine. It's not effective in PH2, and we think that PH2 is actually a systemic disease. That might be the reason why it's not working if it's only targeted at the liver. And the study in low eGFR patients are now still conducted, but there are some signs that it is as effective as lumasiran. So what is the benefit-harm balance for both drugs? There are no important side effects. They are biochemically effective, and there is really evidence for clinical efficacy. And we do have no other effective therapy except very invasive liver transplantation for B6 negative patients. The downside is that there is rest hyperoxaluria in many patients. There's inter-individual variation. In geo-blockade, we don't have good data for nedosiran yet, and we don't have, of course, data on the long-term side effects and what the impact is on long-term high glycolate levels. And last but not least, they are extremely expensive therapies. So our conclusion is there's a clear indication for RNA therapy, we think, in B6 negative patients with a severe disease. It should be individualize the prescription, and it may be in selected case also be an alternative for liver transplantation, and we think they are not indicated if there's a complete response to B6 therapy. And you can read all these recommendations in the clinical practice recommendations for primary hyperoxaluria, as has been published in Nature Reviews Nephrology this year. This is my team, and I would like to thank you very much for your attention. Happy to take questions. And this is a slide showing you the next webinars of ERKNet. Thank you.
Okay, thank you, Jaap, for this very comprehensive overview of RNAi therapies in primary hyperoxaluria. I myself was a little bit struck by one of the first slides that you showed, wherein you show that nephrocalcinosis score decreases very much upon treatment. So I had not realized this, but that means that the pathogenesis of nephrocalcinosis has to be very dynamic for it to be able to be reversible with the therapy which is targeting the liver.
Well, this is a very good question, and it's also one of the most questionable outcomes, to be honest. It's based on scores, and scores are very subjective. But on the other side, I know from one of my own experiences, we had two boys with a B6 sensitive mutation, and the one was unfortunately came in with end-stage kidney disease, so we could treat the other one, and he had severe nephrocalcinosis, and on B6 the nephrocalcinosis completely disappeared, really completely. So it can occur. I'm not, and these observations were blindly made, so we have to rely on them, but you always have to be careful for the interpretation. But overall, the official outcome was that there was a decrease, and I have seen that it is possible.
Yeah, and the other thing that I found striking is that some of these patients, also after transplantation, still have a high oxalate, high urinary oxalate excretion, and together with the fact that you say that these oxalate stores in the body can be high for a long time. Is this actually, let's say, the body stores that are being excreted at that moment? Do we have any data on that?
That's the $1 million question. But we know that also after combined liver kidney transplantation, the oxalate excretion can be abnormal for years and years. In one of my patients, it lasted 8 years after liver transplantation before oxalate excretion was normalized. So yes, the storage can be huge. So we can still look also under lumasiran at a release of stored oxalate, but we're not sure, because we also know that not in all patients there's a complete normalization of oxalate production, and it's very hard to distinguish from oxalate coming out of the stored tissue storage in tissues and production.
I have a question that was posted in the question box, which asks regarding the targeting of LDH by nedosiran. Sabrina Heubel is asking this question, and she wonders that there are no side effects to knockdown of this ubiquitously expressed and highly essential enzyme, and is it tolerated due to the exclusive uptake in the liver? Or is there another explanation for that?
Yeah, important question. Actually, there are many isoenzymes of LDH. So this is LDHA, And what we know is that there's also a family with a knockout of LDHA, and that family also has no phenotype. So probably we think LDH is extremely important for all kind of metabolizations, but that occurs to be other isoenzymes of LDH. So yes, we knew already before, because otherwise this therapy would never have been approved. The same as in GO blockade, that there was a family with this genotype with no phenotype. And yes, this is only targeted to LDHA and only in the liver. And the fact that it is only targeted at the liver is, in our view, our Amsterdam view, the reason why it doesn't work in PH2, because GR is actually an enzyme that is functional in many tissues. So this part of the glyoxylate metabolization does not only take place probably in the liver.
And the other thing that I was wondering about, because you said that the GO blockade also does not give side effects, or at least did not give acidosis. And there's also this family, of course, that doesn't seem to have a phenotype. But what would you actually but in one of your slides you do say that we don't know yet what this let's say prolonged inhibition of GO can give as a side effect profile. What could we expect?
We don't know. There are some people in the oxalate world who think that it could be dangerous on the long run, especially if you also have kidney failure. But to date, there are no signs of it. And there's, of course, only one family prescribed with this GO phenotype, blockade phenotype. And this family is without genotype. This is without phenotype. But yeah, we're not sure. That's the only thing I can say. But on the other hand, we have quite some now we have nearly 5 years follow-up of some of the first patients, and we don't see any acidosis at all, at least in those with normal or reasonable kidney function. So probably it doesn't mean anything.
I have another question from the question box. This one is from Maria Smurley, who asks, what is the need for therapy while in dialysis? And are there any extra renal manifestations that you also try to treat then?
There's a high need, because while you are on dialysis, and even with 6 times per week chemo and PD, you can't cope with the oxalate production if you don't do anything in B6 negative patients. So the longer you stay on dialysis, even with these terrible regimens, you will have more oxalate storage in your tissues, and that really helps with in this way. Lumasiran really and also Nedosiran, I guess, will really help to bridge to transplantation. So yes, I think it's extremely important to start as soon as possible in dialysis patients.
And the other thing that I was wondering about these B6 responsive patients, is this B6 therapy so successful that we should not think about adding RNA interference therapy to the B6, or is that also a possibility for the future?
Well, we know from the whole group of the G170R and the phenylalanine 152 isoleucine with the minor allele, that combination, from if you look into the database, and some of them, a lot of them are only transplanted with isolated kidney, that they are doing as good as those who are have a double transplantation. So for the whole group who are homozygous to these 2 mutations, probably you can do also without RNA therapy. On the other hand, we also know that there are some patients who do have this mutation and still have some hyperoxaluria. So it might not count for all patients. That's the difficult thing. So that's why you should really personalize it. But if you don't have access to RNA therapy, then we recommend in patients who are homozygous for these two mutations to perform only isolated kidney transplantation.
Mm-hmm. Yeah. And then we already said previously that there were some $1 million questions, but of course it's expensive, so that's also kind of a $1 million question. So is this now available in all, well, let's say EU countries? This is an ERKNet webinar, but you could also ask this question for the entire world. And how are insurance companies, etc., dealing with this?
We know that it's different in each country, and for instance, in France, it's free. It's very easy accessible. We know in Belgium it's accessible, but it takes quite a long time before it is approved per patient. So officially it's accessible, but in practice it can be difficult. There's a huge discussion in the UK, and so it differs per country. Yeah, so the situation is really different everywhere.
Mm-hmm. Yeah. And can you say something about the Dutch situation, maybe? How?
Yeah, we have a special. So we made an arrangement with the insurance company that we formed a national board in which we have a nephrologist and a pediatric nephrologist of all the academic centers. And we made a protocol, so all patients who are eligible for RNA therapy, they have to go through that protocol. We decide based on this protocol if a patient is eligible or not. And then they have to be followed, they have to be registered, and we decide after 6 months of therapy if the response, biochemically response, is what we expect from it. And after and then we follow the patients for 4 years, and we decide every year if there's enough clinical response to proceed with the therapy or not. And patients are obliged to register, and so now we have 17 patients in this protocol, and we have refused the therapy in 4 of these patients. And the good thing for the patients is also that they are very well has a very strict follow-up. And one patient who needed this therapy as soon as possible could actually start within 3 days after admission with the therapy. So this might be a protocol for other countries. I think it's takes a lot of effort for the physicians, to be honest, but I think this could be a model for other countries.
Yep. Yeah. I have another question from the question box, which is a specific patient-related question from Lucas Bergerhausen, who says, we have a patient with persistent hyperlactatemia, so high lactate in the blood gas analysis under lumasiran and nedosiran double therapy. And do you think that this might be glycolate or other metabolites that we accidentally measure in the blood gas machine? Or do you have another explanation? That's the question that I add to this question.
Oh, that's very interesting. My first question to him would be: did he see a further is it the dialysis patients, and is it and did they see a further reduction of plasma oxalate, or if it's not a dialysis patient, urinary oxalate under this double therapy?
And maybe he will he will answer that, and maybe he won't. so maybe you can tell us why you would think that is relevant.
I will try. Yeah, I will try to answer this question. Actually, so it's important to know if it is a dialysis patient, because then I can understand it more clearly. I can understand it better. We know that, of course, that glycolate goes up in lumasiran, but it was never measured in the nedosiran studies. But we know from our own observation that glycolate can also go up under nedosiran. So it might be an additional effect on glycolate levels. So yes, indeed, it might be related to glycolate, and then it becomes interesting, because then those who think that very high glycolate levels may indeed lead to acidosis, this might also be lead to lactate production. I'm not sure, but we should actually in this patient then measure glycolate, glyoxylate if possible, and see what the oxalate levels are with only lumasiran or double therapy. I don't know if the double therapy was directly started or that it was sequentially started.
Our colleague has answered in the meantime, saying that yes, the patient is dialyzed, PD every day, and HD, so hemodialysis 4 times a week. And that glycolate is massively increased under therapy in the range of 1,000 micromoles per liter.
Yeah, so it might be additional effect of nedosiran also on the glycolate levels, and maybe these levels are so sky high that that these levels it might cause problems. Yeah, but he can send me the case if you, and then we can have a look in it at it if he is interested in it. Very interesting case.
Yeah. He also adds that the therapy was started sequentially, and the lactate raised after lumasiran was apparently added. So that
he started with
nedosiran.
Yeah. Okay.
But I think that we are now getting too much into the specific patient case. Again, Jaap, I would like to thank you for this presentation and for telling us, let's say, the up-to-date story about these RNAi therapies in hyperoxaluria. I would like to thank everybody that attended today, and I would like to ask everybody to pay attention to our next webinar schedules, and the next one will be the one on the TSC guideline at the 5th of March. Well, thanks again, everybody. Hope to see you next time, and have a good afternoon.
Thank you. Bye.
Bye.